this Friday afternoon to talk about something really important. Actually, to be talking together about how healthcare is supposed to be for everyone, and in particular for the high need and challenging and complex patients that we are really, I hope, intending to serve. So let me just begin by pitching a number of thought questions to you before we dive in. And let me just also say, I'm a health psychologist by training. I grew up in West Los Angeles, and as a kid in Santa Monica, I had this crazy dream that I wanted to grow up to become a Spanish-speaking psychologist, even though my family was not Spanish-speaking. And part of that was, very personal. My parents divorced when I was young, and my mom took me to see a therapist. It was a very, very powerful and healing experience for me. And as time healed, and we all got stronger, I had this idea that I wanted to be that guy. I wanted to really work with kids and families and couples, and really be part of the healing process for others. So that was part of it. And then the other part was my friend Nicky up the street. From his family was from Argentina. I spent a lot of time with them and just loved the musicality of the Spanish, and put it all together. One day I did this kind of gap analysis for services in Los Angeles in my mind, and thought, if I could become a psychologist and I could learn to speak Spanish, I could really help a lot of people. And so from that point, it was all following that calling. High school, college, graduate school, all about getting Spanish and psychological training. And then, so fortunate, my dream actually came true. For 20 years, I worked as a Spanish-speaking psychologist at White Memorial Medical Center in Boyle Heights in East Los Angeles. And there I felt deliciously immersed in the very precious immigrant community, and provided mental health services right in the context of primary care. And also as a faculty member, I'm training the young family medicine residents about doctor-patient communication and whole person care and integrated care and culturally responsive care, such that we could really take a hatchet to the health inequity problem in the local area. So anyway, that's been my journey. For the last 4 years, I've been working as a healthcare consultant and health management associates, and really working with organizations to ever improve how we deliver care to vulnerable and safety net populations. I'm so sorry that my transformation coach partner, Dr. Brandon Fells, is not able to be with us. She is away on a family vacation, but she sends her warm regards, and I will do my best to represent her. All right, so let me ask you just a couple questions to think about with yourself for the next few minutes. How do you define who is a complex patient? To what degree are you looking at their medical challenges and their behavioral health challenges, perhaps their social needs and challenges? And then for a moment, let me ask you to think about your organization. To what degree would you say you are offering integrated services? There's a very beautiful sort of continuum put together by SAMHSA. Services can be, apart, right, where you refer someone to mental health services across town and hope they make it. They can be co-located. They might be in the same building, but not necessarily together. Or they can be much more integrated. They might even be where behavioral health and care managers and nurse care practitioners and physicians and all work shoulder to shoulder in a team approach in the same clinic pod or hospital setting. How integrated is your organization, and what do you see as opportunities to enhance that? Who would be on your team, do you think? Who makes for a truly and full integrated team? To what degree are you partnering with patients and their caregivers and their families To what degree is this a big, inclusive, shared health healing endeavor? Let me ask you this. How do you know if what you're doing is making a difference? How do you know if you're really helping your patients to improve? How are your teams engaging with folks? And what do you do when patients aren't so interested or ready or willing or trusting to receive healthcare services? And the final thought question to frame our discussion: who are the enlightened leaders in your organization? And to what degree are they really behind these emerging models of healthcare? To what degree would we say they are champions, that they are cheerleaders, that they can articulate the pathway forward for whole person care? Well, all of these questions that I just asked you, we had to ask ourselves about 3 years ago when we began a brand new pilot working with the Inland Empire Health Plan. The Inland Empire Health Plan, under the direction of Dr. Brad Gilbert, had a dream, had a vision of truly enhancing care delivery for complex patients that had both behavioral and health needs together. And IEHP, as a sort of Medicaid, Medi-Cal, public health plan, decided to invest heavily. They found a team of folks to really work with them, and that has been our journey. And it's been a very successful journey, which I'm excited to share with you today. This pilot project just ended at the beginning of August, and we are now poised to grow the project moving forward, which I will happily share with you as well. So the project goals were to establish both integrated behavioral health and primary health care, and integrate complex care management. So this is really a beautiful woven tapestry. We want to provide integrated, coordinated, and team-based care that is patient and person-centered, that is relationship-centered care. We want to be sure we're addressing the mental health and the substance abuse conditions, the contributions of health behaviors to their illness, looking at life stressors, crises, really a team of folks able to work shoulder to shoulder with patients and their caregivers to manage whatever may be going on, and hopefully over time to encourage self-management, autonomy, independence, helping patients get back to the life that they want to live and deserve to live. So these are some key points that we have taken from our pilot. One is that intensive efforts are required to truly implement complex care in a very complex healthcare environment. And we took it on in two different ways. We put some teams, some healthcare and behavioral health teams into primary care medical settings. And we did what you might call reverse integration. We've been putting healthcare teams into typical county behavioral health or mental health clinics. So both ways, because patients in both places need all kinds of care. We decided that if we're going to deploy these teams, that we wanted to ensure their success, and we provided coaching. And so I served as a transformation coach in partnership with Dr. Brandenfeld, she being an internal medicine doc and I as a psychologist. And then the two of us would really meet with our teams live once a month and regularly by phone call and by email. The pilot, as you will see, is rather complex. It has a lot of measurement pieces. And we really felt like being able to support them with our warm hands on their back, and providing a relationship-centered coaching in parallel to the relationship-centered care they're delivering to patients would really be an important model. And it turns out that was, in fact, a key success component. BHI-CCI, our behavioral health integrated complex care initiative, did have a major impact on patients' experience. One person told us, for me, I really think they saved my life. Sustainability was a serious focus, and we are now indeed going to move forward with a new sustainability plan toward California health homes. If you are interested in learning more about our project, this is the website, and it is a treasure chest of resources. It will provide you everything that I'm talking about today and much, much more. We've done a lot of training, and the training materials are there. We've done a lot about measurement in our data plan, and that is there. There's information on just about anything that you will be curious about in terms of integration. So our story takes place in the Inland Empire, in San Bernardino and Riverside counties, just to the east of Los Angeles and Orange counties. And these are challenging areas in many ways. 55% minority rate, lots of folks with limited education. And let me just pause here for a moment to remind us that education level is one of the best predictors of health status that we have. It's linked, of course, to employment. It's linked, of course, to economics. But education is very, very important as a social influencer of health. The Inland Empire is challenged with unemployment rates that have more than doubled since 2007. They are higher than in the United States and in California. The poverty rate is quite tragic at 12.7. I remember reading this quote: "Statistics are like people with the tears wiped away." I always think about that when we're looking at these numbers. They're just numbers, black and white numbers on the screen. But these are the stories of people's lives. These are about day-to-day challenges to make life work in the face of so many barriers. Mortality rates in the Inland Empire are not that surprising. Heart disease and cancer and lung disease, stroke, many unintentional injuries, and diabetes rates are 5 times higher for the Latino population. What is also important about this list is how much of these are preventable. We have the knowledge and the technology and the capacity, in theory, to really make an impact here. But there is room to grow in how we actually unfold that for people in a preventive, educational, and interventional way. Healthcare system in the Inland Empire before this project and continuing is one of limited providers, partners who are very isolated, not that kind of co-located experience. Behavioral health resources are disconnected from physical health. Care was fragmented. We all know how easy it is for folks to fall through the cracks when provided with a referral. Poor health outcomes, a lack of IT infrastructure. This is very challenging across the land when our systems don't talk with one another in a meaningful way. We can't share information. And of course, very high costs. So this project is kind of a triple aim project, right? We want to improve outcomes. We want to improve the patient's experience of care, the relationship quality care they're receiving. And we want to cut down on the costs for ER visits and hospitalizations. And we actually would like to do a quadruple aim approach. That fourth leg of the table being attending to the practitioner's wellness and vitality. It is not easy to provide care to complex individuals and challenging patients and families. And we wanted to monitor how were they doing along the way. The problem of accessing mental health services is terrible. So of 10 patients, 6 will never get treatment. 2 will maybe get to mental health care through their primary care, if there are resources there and available. And 2 will actually make it to a real live mental health practitioner alone and apart outside of the physical health setting. I remember so well the extraordinary access that patients in my clinic in Boyle Heights had. They would come in and see their physician. They would have received a bad news diagnosis. Maybe they facing depression or anxiety. Maybe there was a child abuse or domestic violence issue at hand, and the physician could just grab me down the hall, and together, shoulder to shoulder, we would work with the patient, family, and caregivers to make a difference. And there's no stigma. You don't really have to go to a mental health clinic. You just come see your doctor. And there I was. This is a $30 million investment by Inland Empire Health Plan. Health Management Associates has been really deploying the project and coaching. And the University of California at San Diego was brought on to assess the outcomes and the impacts of the project. So some of the data that you'll hear today comes from their careful and thoughtful attention. We have some basic commitments in this project. We want to improve patient and team experience. We want to improve care coordination and integration of primary and specialty and addiction and mental health care across and between healthcare and treatment settings. Keep thinking about that beautiful tapestry that we're weaving. We want to improve complex care management of individuals with chronic conditions. We want to improve population health. We want to use some really cool data analytics to guide not only our assessing if we're making an impact, but to guide the care as well. And we'll talk more about that. Improving access and reducing overall healthcare costs in the Inland Empire safety net. So what do we do? This was a 24-month pilot. We have 33 sites. As I said, primary care and behavioral health, hospital ambulatory care clinics. We wanted to really build these teams into health homes where patients would get all kinds of care, and it would be whole person and relationship centered. The way we defined our target population was those with two chronic conditions, a physical health condition and a behavioral health condition. So you might think of a patient with diabetes and depression, say, or hypertension and anxiety, or COPD, pulmonary disease, and housing and social services challenges. We wanted to choose folks that we felt could really benefit from the care team's interventions. We wanted to work with people that were high cost, going frequently to the emergency room and the hospital, and of course, all IEHP members. We started to build this project on a foundation of quality, and the Institute for Healthcare Improvement has this breakthrough series learning collaborative model, and that was the foundation. That we wanted to have small tests of change that would let us know whether our innovations were really making a difference. We can all have good ideas about how to help people. We were constantly paying attention to how we know whether what we're trying really has the impact that we were desiring. So again, we had practice coaches who facilitated our teams to have that kind of embrace that same kind of thinking. Let's try something. Let's do it our way. Let's see if it really is making a difference. So each of the clinics, I would say, in some ways, really followed a roadmap on this project, but in many ways, each team found their own way forward that made the most sense for who they were, for who their patients were, and for the clinic in which they were deployed. We asked healthcare organizations to apply to participate so that there would be some buy-in, some skin in the game. And we wanted to increase staffing and practice changes. So and I'm going to tell you a little bit more about who these teams were that we put into primary care and behavioral health. But they were, a lot of the money paid for their salaries, paid for these teams to grow and to embrace patient care. So let me show you our roadmap. And as I said, there's more of this on our website. We started with leadership engagement. I asked you earlier, who are your leaders, and how visionary are they about integrated care, and how can they articulate, to what degree can they articulate the value for that, for care delivery? Without engaged leadership, we've learned we cannot go very far at all along the road. It's really important to have that shepherding. Then we wanted to engage the teams with coaching and with a lot of resources and education so that they are primed and ready to work in ways they may have never worked before. And our teams of behavioral health clinicians, they need to know and be able to talk a lot about diabetes and hypertension. Our nurse care managers, they need to know and be able to talk a lot about basic counseling skills and depression and anxiety. We wanted to cross-pollinate skills and knowledge as much as we could. The basic dedication to partnering with patients and their families and their caregivers. This is a team approach to care. And actually, in many ways, it is the patient and the family who are the most important members of the team. They let us know whether what they need and how we can help, and whether the help is making a difference. We wanted to develop a project that's built on data and measurement. We know whether we're making a difference or not. Our teams will know whether they're making a difference or not. We have a good quality improvement method, which I mentioned. We want to be sure that our teams are doing a good job identifying patients that are complex indeed. And that was a bigger challenge than we thought. I'll tell you a little bit more about that. We wanted to build multidisciplinary complex teams. And we wanted them to have a unique and precious way to meet and talk about patients, something we call standardized caseload review. It's not a typical case conference that you might hear at a mental health or a medical clinic, but a very focused, action-oriented approach to talk about patients who need more. We wanted to integrate behavioral health care with complex care. We really wanted to sustain the change. So who are these teams that we've deployed? For the first 2.5 years of the project, the teams consisted of the following. They were triads. We had a nurse care manager, we had a care coordinator, and a behavioral health clinician. And as I said, although each of them brings their specialties, we wanted them to work outside of silos. What we really wanted was each of them to become the best friend, you might say, of patients and families. To be the person that someone can call when they're really stuck, or they can't get their Social Security, or they can't get their appointment with the orthopedist, when they're having housing challenges, or there's been a substance abuse relapse. We want our teams to be there and accessible and available to sort of be the face of true healthcare, something which patients, particularly underserved patients and minority patients, so often lack. For many of these patients before this initiative, healthcare was maybe 15 minutes every 6 or 8 weeks with a physician or a nurse practitioner or a PA. We have recently added another member to the team. You're now moved from triad to quadrad, and that is the community health worker. Community health worker is that incredible addition to the team who faces not so much in the clinic, but really faces into the community and is arms and eyes and legs and voice and warm embrace for patients in that way. And as we move forward with health homes, the next chapter, our community health workers will be very central. And we're working just now on helping the teams move toward integration. I love this quote by Maya Angelou. She said, "I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel." This was our key and core commitment to our patients, that we will do everything we can to help them feel attended to, cared about, and less symptomatic, feeling better in all ways in the context of relationship. So a very important piece of this project is the population health piece, right? So each of these quadrads is responsible for 150 complex patients. Now, how do you know if you're monitoring 150 patients like how everybody's doing. How do you decide when you come in on Monday morning who needs what, who you're going to help or call or work with? Is there some way that you can really have an instantaneous guide to knowing what's the next step for intervention? We developed something. We didn't develop it, actually. This was developed by the Ames Center up at the University of Washington. Their website, the Ames Center website, if you're interested in this, is an extraordinary place to learn a lot about everything you would ever want to know about this kind of integrated care. But this is very detailed, but this is essentially an Excel spreadsheet. You actually can download one from the Ames Center and start using it on Monday if you like. But what's so wonderful about this registry is that I can sort my patients. I can sort my patients by their PHQ score, right? Every time we see them or talk with them, we measure their depression level, the Physician's Health Questionnaire 9. So I can, with a push of a button, I can line up all my patients and see, oh my goodness, I have 14 patients that have the highest, way out of the stratosphere depression scores. We need to work with them fast. I can look at anxiety scores. I can look at their A1C, their degree of diabetes. I can look at their blood pressure. I can even screen for which patients are highest on both diabetes and depression. This is a beautiful way to get my arms around my population of 150. And our teams, they know this registry like the back of their hand. They use this data to guide their work. They are dedicated to being sure that they're regularly collecting data from patients at visits and on phone calls so that we do have kind of the latest snapshot of what folks are struggling with. But not only that, the registry, this data is not just for the team. We have taught our teams to look at the data by one individual and to share that data with patients, that it becomes part of the clinical conversation, that it is data-driven care. So I might sit with a patient and I might say, hey, look at this. Look how your depression scores started to drop about 4 months ago. Remember when we started meeting together and talking about new and better ways to think about your problems and to get you a little bit more active and physically active? And notice how about 2 months after the depression starts to drop, notice how your diabetes has begun to improve. What do you make of that? And we can have a conversation about that. What I make about that is that if you do a better job taking care of your mood and mental state and caring more about who you are and taking the warm caring that we're giving you, that begins to reflect itself in less depression, which gives you more energy to take care of your physical health and to check your blood sugars and to make wise health choices in what you eat. We also can use the data to drive a different kind of conversation. Whoa, look how your anxiety and your blood pressure have been unmoved for 3 months after a little bit of progress. What was going on that was so helpful before? What's not going on now? And how can we work together? What do you need? So data-driven care, registries for population health, very, very essential pieces of this project. And thank goodness for coaches. Thank goodness for Emily and I being accessible to our teams as need be to be able to help them be sure that they get this. I hope you're hearing the parallel. I hope you're hearing how the coaches are available in a relationship-centered, problem-solving way with our practitioner teams, in the same way that our practitioner teams are available and accessible and ready to help the patients and families and caregivers that they're working with. There are a lot of new skills to develop. Behavioral health clinicians, as I said, are learning about diabetes and vice versa, and a lot of other elements of being successful. And these are the kinds of things that we've been training our teams in. And again, a lot of these materials are also available on the BH Integration website. How do you outreach and engage with patients? They're not trusting, or they're not eager, not ready. What about health literacy? How do we talk about patients? No, excuse me. How do we talk with patients about health issues in a way that makes sense to them? How do you describe diabetes to a patient without using those words, like big words like pancreas and glucose? Health literacy is essential for patients and families, caregivers to be able to own and understand what's going on with them. We've been teaching a lot about enhancing medication adherence, and in a patient-centered way. It's a lot about education. It's a lot about readiness to change. It's a lot about motivational interviewing, for those of you that have been trained in that. Motivational interviewing is a way of working with others toward behavior change that has been empirically shown to be much more effective than giving advice. And giving advice is pretty much what we do in healthcare all the time, whether our patients are listening or not, or ready or not, or understand or not. In this project, we really we start with a motivational interviewing and health literacy approach. All eyes constantly are on patient self-management. It's all about their ability to take care of themselves. And if you can't quite do some of that stuff at the beginning, we're happy to help. We're happy to help you manage your medications. We're happy to help you get to the orthopedist. We're happy to help you with substance challenges. And over time, we will continue to assess how you're doing. And at some point, we may all feel like you're doing better. The data is showing you're doing better. You're telling us that you're doing better. You look so much better. Maybe it's time that we begin to think about helping you go back to care as usual. This high complexity intervention is really, we've done our work here. We've done our work here. You're ready to fly. The work is shared. There's shared care planning. Your objective for the care may be to be able to feel better so you can go to your daughter's wedding in February. And we may have a piece of that where we really want to decrease your anxiety and your hypertension. So we can maybe agree to work on all those things. Our teams really need to know how to manage registries and manage those transitions of cares that I just started to talk about when folks are no longer complex for a number of months. How do we help them get back to care as usual, but internalize all the work that we've done, and to know that we still are here if you need us in the future. This last component about cross-system leadership was pretty revolutionary. We asked folks, so remember I told you there were 33 organizations, clinics, all different types that are doing this behavioral health integration work. We asked the leaders from each of them to come together and to learn about collaboration in ways that maybe they had never thought of before, to build a network of support between organizations that didn't maybe even know each other existed, or maybe even were competitors in some areas. The projects, the learning, the network, the tapestry that we wove between the participating organizations was extraordinary. They took on projects to manage what happens when patients are in the hospital and then need to get back to outpatient care and vice versa. They manage, they develop projects to really improve how organizations were talking with one another about the care that they were providing, in some cases to the same patient. So what have we learned? What do the data tell us about this huge undertaking and this huge effort? First, patients with elevated behavioral health scores at baseline had lower scores at their last follow-up assessment. In other words, we're making a difference with depression and anxiety. 2, patients with elevated HbA1c, the diabetes marker, and blood pressure scores at baseline experience improvements in their scores as well. We are impacting physical health. About cost, overall, reduction in inpatient costs compared to a control group. So win-win-win all the way across. But I want to say something about our data. We realized maybe a little more than halfway into our project that actually when we started to look at the teams' registries, that not all of our teams had done an optimal job of selecting complex patients for their focus. That many of the patients that they were working with actually didn't have very severe depression or anxiety scores, or may have only had depression but didn't necessarily have physical health issues as well. So because our teams had not done that optimal job in finding and working with true complexity, it restricts the ability to really make and show the whole difference that we're making. So we then asked our teams to look at their registries, to clean them up, to really think about doing a better systematic job of recruitment and inclusion of complex patients. And then I think that the data has only improved in terms of showing the impacts since then. Here's a patient voice. I mean, for me, I really think they saved my life, because at the time I was just so frustrated with trying to tell someone something and then they're trying to tell me, like they know my body better than I do. So this team came into the doctor's office, and that's when they introduced themselves while I was waiting to see the doctor. They came in before the doctor, and it's awesome. Someone else says, all the information, appointments, doctors, and reports are in harmony. Oh, if we could have harmony in our healthcare system more consistently, imagine, just imagine. I don't think I have a slide about the practitioner voice. Let's say a word about that. We collected data on the well-being of our teams, and it was high and consistent. And if you ask some of our physicians at the clinics, what was the impact of having a team down the hall, their eyes get wide and bright. You can see the smile crawl from ear to ear, and they will say, I finally get to be the doctor I wanted to be. I finally get to provide care to patients in the way that they deserve it, that I was called to do. Patient comes in, has a lot of needs, more than they can manage in 15 or 20 minutes. They can invite the patient to receive care from the team down the hall. The communication between the team and the physician provides them at those standardized caseload reviews with information they knew nothing about in terms of the unique challenges of patients' lives, and or the presence of or absence of caregiver support. We were very fortunate to receive for this project the California State Department of Healthcare Medical Innovation Award in 2017. Very nice to receive some recognition, although the improvement of the patients is the true award. So where are we now? The federal government, in collaboration with the state of California, now has a health homes project that is unfolding, and the Inland Empire Health Plan will be taking advantage of that, and we will continue to coach and develop and train teams to be able to do that. The good news is that health homes is really, really similar to our behavioral health integration and complex care initiative. Our teams already are very, very close and already have so many of the skills that they will need to be able to be successful. There are some differences. Health homes has a greater focus on addressing housing issues, so we will fortify our teams to be able to do that. Health homes, also the patients are identified by a list from the state saying, hey, these are patients that we feel worried about. They cost a lot and they don't seem to be taking advantage of care. The teams are going to need to find some really new, innovative, creative, patient-centered ways of using the incredible wisdom and experience of the community health workers to find these patients, to invite them in to a new, hopefully trustworthy caregiving experience. So you can see that the Health Homes program is about comprehensive care management. We've done that, check. It's about care coordination, about helping people really get the kinds and extent of care that they need, check. Health promotion and education, yes. There's comprehensive transitional care as people go into or come out of the hospital or into or out of this sort of higher complexity integrated care team care. There's a focus on individual and family support and ready referrals for community and social support services. What I love about my teams when I visit them is to sort of check in and see these incredible resources they've been able to amass for their patients. But it's not just a listing, it's not just a Xerox photocopied list of phone numbers. They've developed relationships, true relationships, so patients can be warmly nurtured from one place to another to address their needs. Just a few things about Health Homes as we look into the future. It's a 90% of federal funds and 10% state match. It'll be 24 months. And clearly for vulnerable patients, it will be a whole person care model addressing physical, behavioral, social needs. It's integrated into medical homes. We're going to, like our teams now, we're going to leverage those places and resources that are available. We hope to demonstrate improved outcomes and savings over the 24 months. And 24 months starts January 1st. So you can imagine we are very, very busy hiring, getting, shining up the existing teams, building new teams at other places, and a lot of training and coaching will be unfolding between now and then. So Libby, maybe I can pause there, and if folks would like to have a little more conversation or pitch some questions, I'm happy to answer.
Absolutely. We've had some good conversation and reflections in the chat box as you were presenting, and I just want to start off by thanking you so much for this great look at the program that you have been leading over there in the Inland Empire. Are there any questions? Feel free to take yourselves off mute and speak up if you have a question for Dr. Ring. It looks like we've got a fair number of patient family advisors as well as healthcare professionals on the line today. So I'm just wondering if any of you are thinking about these kinds of integrated systems, and if you've had any experience, how did it work out for you, either as a patient or as a healthcare professional?
Hello.
Yes.
Hi, my name's Shelley. So I'm wondering, with this program, what were the most difficult things that you had to do? What were the biggest barriers?
I'm sorry, did you repeat the question, please?
What were your biggest barriers that you found during this integration?
We found barriers all over the place. The first one was leadership. Absolutely. If you don't have a leader who is going to really fight for this, you can't get very far. Change is tough, and inviting a new team into a clinic is tough. Everything from getting space to building relationships to figuring out new workflows, these are all really tough. And without leadership, you can only go so far. The second was moving people out of their sort of comfort zone. Trained as a behavioral health clinician, I was trained in graduate school to work with patients, talking with them for about an hour in an office. That's not the way our behavioral health clinicians work. It's certainly not the way I worked at White Memorial. I was in the clinic all over the place, going into exam rooms and doing very brief interventions and assessments, doing some behind the scenes advising of the physicians how to talk, say, in a trauma-informed way or a culturally responsive way about depression or anxiety, say. So moving people out of silos is a big barrier. And the next one that occurs to me is about data. It's really a new way of thinking, this population health way, where we're using a registry, that we're really trusting that these measures do indicate changes that are happening in people's lives, and being able to use the data to, one, decide who to work with, and two, to be able to look at the data in clinical encounters with patients themselves. That one, I would say our teams have really excelled at, and they feel very empowered by, and they have really, I think, embraced the great utility of data-driven care in a shared relationship kind of way.
Yeah, I thought that was really interesting, the way that you described that. And I even put a note in the chat box that in the way that you described looking at the data to really support the conversation with the patient and the family, that really resonated with me. I think it's a very delicate balance where the data dictates the conversation versus really is in support of the conversation. So, I've seen it presented both ways, and I think that's a finesse point, if you will. I've seen it presented in the way that you talked about it, in terms of, gosh, look what what you've accomplished here, as well as this is what it's showing, versus look at what you've done, sort of, and it's such a nuance. I've seen it go both ways. I think that's a very delicate balance, and I really appreciated the way that you described it.
Well, thank you, Libby. It's a little bit more common in medicine, I would say, to say, hey, your blood pressure, over, is it up or down? We've probably had that conversation with our physicians. But not so often do we get to see the data, and not so often do we see or look at or get our mental health, our behavioral health data, and very rarely do we ever talk about them together and how they're linked. But in fact, they are linked. We, tender, delicious, and complex human beings, we're linked, right?
Mm-hmm.
I feel very like getting out of bed. I'm not going to eat healthily. I'm not going to move today. I'm certainly not going to measure my blood pressure, and I probably won't take my medicine. So we can move everything all together.
Right. We are complex beings. I think, let's see, Janice has had her hand up for a bit. Janice, did you have a question?
Yeah, I just thank you for that. I felt it was very important and well done, and covered everything in a fairly simple manner, plain language. And I did appreciate the data too. And I think you had mentioned part of that comes from the state. I just want to say I'm from Kaiser, Washington, used to be Group Health, and we implemented health homes quite a while ago. And that was a huge transition, I know, doing that. And it's a constant process of bringing in the latest and best evidence-based practices, like open notes, choosing wisely, and implementing them into a system where individuals, patients don't even realize that the initiatives have been implemented. But my question is, how do you continually update or upgrade your best evidence? And when you see something isn't working, is it like a lean process, or is it just daily huddles, or how do you do that?
Yeah, that's a great question, and congratulations on your health homes success and investments. That's really cool to hear about.
Yeah.
All of our teams about small tests of change, and this comes from the Institute for Healthcare Improvement, but this PDSA, Plan, Do, Study, Act,
right,
methodology helps us say, for example, the team is like, we we need to figure out a better way to find out who the complex patients are in our clinic who are already on the schedule, so that we can identify them and maybe reach out to them once they're here in the waiting room. And so they would have to think about, well, what's the best way to do that? Maybe it's the front desk person, or maybe it's one of them that's going to scrub the charts the night before or the day before. And then they would try something, and then they would, collect some data on it, just short, about a couple days, and they'll know pretty well whether this seems like this is something that's going to flow well and not cause new and additional unexpected challenges. So I think armed with that kind of critical thinking and measurement tools, our teams have really been very savvy. And I think they feel empowered to be creative and innovative because, if it's not going to work, it's not going to work. And if it's going to work, we'll know pretty soon.
Great conversation. We have a couple more questions in the chat box. One from Nancy. She's wondering if you used patient engagement techniques like motivational interviewing. I think you mentioned that one, and the patient activation measure, I think is what she's asking about. Yeah. Any of those tools that you used?
We did not use the patient activation measure, although I hear really great things about that. We certainly do use motivational interviewing, and we do shared planning together to really sort of be sure we're all on the same plate with what we're going to be focusing on. We also have not used as many decision aids for shared decision making, and I would say that is on the to-do list for us. Decision aids and shared decision making is a very rich and evolving field now that helps us when we have to make a choice for ourselves or a loved one, and gives us the useful data in a way that we can really digest it in the context, again, of a supportive, caring, informed relationship. So yes to motivational interviewing, not so much for the patient activation measure, and not so much, but more coming on shared decision making.
Great. And we have another question from Joe Connell. How do you get input from patients and families when designing and improving programs? The appearance seems to me that the program was designed by experts and done to patients rather than with. Is there opportunities for your patients and families to inform that PDSA cycle and let you know how the actual program is working for them? And were they able to help you co-design the program itself?
Yeah, good question. So the program itself was designed without as much patient and family input, and really built on the kind of the research base, much of which does come out of University of Washington and other places. Mm-hmm. On a more micro level, on the patient experience level, on the delivery of care, patients and their families and caregivers tell us everything. Pretty much in every session, we ask our teams to ask, how is this going? What's most helpful about what we're doing? To what degree are we meeting or not meeting with the objectives here? Mm-hmm. So it's really to have very frank conversations and take in the perspective and the needs and the wishes and the desires and the expertise. I would say that is very much embraced, but it is much more embraced on the clinical intervention level than on the larger design.
Yeah, and that's of course something we do hear regularly with PFCC partners is encourage those that voice, that perspective that you just described, getting at the clinical level and bringing it even further upstream to inform the design of what the goals of the program might be, or how your patient family populations might influence that. So, but I think it's fantastic that you're. Sorry, we're having a fire truck go by. I think it's fantastic that your staff is so actively seeking that kind of feedback as well. And then I think we have time for just maybe one quick more question. Let's see, where did it go? Connie is interested in the transition back. With this population particularly, sending them back to the same processes that failed, how does that work? Does that initiate another cycle into the system, or how does that work? Or maybe you haven't gotten far enough out. I don't know.
Yeah, we have more to learn about optimal transitions, but what we have been doing is two things. One is we talk about the ultimate transition with patients from the very beginning. So we all kind of have our eyes on the prize of sorts. We all understand that this is, this is like a time-limited specialist kind of intervention. It's like if you have a kidney stone, you go to the surgeon, and she, and their team will do everything they need to remove the kidney stone, and then you'll go back to your primary care physician. Similarly, when someone's arriving with a lot of complexity in their lives, the team will work with them until the complexity, like we just dial down the volume on all of that.
Mm-hmm.
People are much more self-autonomous, and at that point, they will sort of go back to care as usual. But you are absolutely right. We don't send somebody back to care as usual until all of us sort of agree and feel like this is the right thing to do. We have at least a minimum of 3 months where we're sort of weaning, say, from the more intense team care experience to care as usual. And during that time, we're watching numbers, we're having conversations, and we're really assessing. But you're right, life is complicated and hard to appear, in
Sure.
6 months, and the housing challenges are real. So do our best to take on as many of those as we can.
Great. Well, thank you so much. What a great program, and I really appreciate you sharing. Much success, continued success to you and your team, and to everyone who's joined us today and participated in the conversation. Thank you so much for taking an hour out of your busy schedules to join us. I really appreciate it. Please feel free to follow up with us. Dr. Ring's email is on the screen, and you can always find us at pfccpartners.com. Thanks so much. Have a wonderful weekend, and we'll talk with you next month.